Hey guys, so in this video we are going to talk about two pathologies that are highly associated with primary hemostasis. If you had not seen the video on primary hemostasis, I encourage you to go back and watch it. But there are two pathologies, and I'm not going to include any of our MAHAs like TTP, ITP, any of those, but we are going to talk about two congenital inherited autosomal recessive diseases that particularly affect primary hemostasis. The first one is called Bernard-Soulier, and again, it is autosomal recessive inheritance. And with Bernard-Soulier, there is a defective GP1B. Defective GP1B, which, as you could imagine, if GP1B is not functioning, then there's nothing for VWF to bind to, and thus platelets cannot aggregate. So we would see a decrease in platelet aggregation. Okay, defective GP1B receptor. And in Bernard-Soulier, they tend to have large platelets, and they can have a low to normal platelet count. So, question on lab: what lab value would be elevated? Bleeding time, PT, PTT. Good job. They would have an increased bleeding time because this is a problem with platelets alone, right? This is not a problem with the clotting cascade. This is only a problem with primary hemostasis. Now, with Glanzmann, which is also inherited autosomal recessive, with Glanzmann, there is a defective GP2B3A receptor, which means that the platelets cannot link together. Now, there are two things that I want you to remember about Glanzmann. There is a drug or a set of drugs that have the same MOA as Glanzmann. And they are called GP2B3A inhibitors. I always think I like to eat. So the names of these drugs are eptifibatide, abciximab, and tirofiban. Okay, these drugs have the same MOA as Glanzmann. Now, we'll get into pharm later. This is just for pathology, but also keep in mind that another disease called ITP, immune thrombocytopenic purpura, this is due to IgG antibodies against GP2B3A. Why do I throw that in? Because they love to test on this, right? They love to ask that question. I recall on a practice exam seeing a question about which of the following drugs has the same mechanism of action as this pathology, and the pathology was clearly Glanzmann. And I had to remember that abciximab was that drug that had the same mechanism of action as the pathophysiology behind Glanzmann. Now, Glanzmann, they still do have decreased platelet aggregation, but they often have a normal platelet count. Okay, and keep in mind that on lab, what lab value is going to be increased because we're talking about primary hemostasis. Very good job, right? Increased bleeding time with a normal PT and PTT. And it's the same up here, a normal PT and PTT. All right. So I did not throw VWF deficiency into primary hemostasis because it's also heavily involved in secondary hemostasis. And I want to wait until you get to that video to talk about VWF deficiency because it also affects not only bleeding time, but it affects PTT as well. So you can catch that in the next one of the next videos, and we'll certainly go into farm here soon. So if you like this video, click like and subscribe. Thanks.